I think that everybody is oriented about the triangles. Sternocleidomastoid and trapezius divide the neck, anterior and posterior triangle, and anterior triangle can further subdivided into this submental, submandibular, carotid, and vascular, muscular triangle. Now I want to tell about the vascular arrangement of the neck. Regarding the vascular arrangement, we can divide the neck into 3 compartments, that is the superficial, intermediate, and deep. This is superficial, intermediate, deep compartment. Superficial compartment lies below the platysma and superficial layer of deep subbrachial fascia. It contains the anterior jugular vein, external jugular vein, and communicating veins. Tips for this first compartment: during the thyroid surgery, to dissect in midline between the medial borders of step muscles, stay between 2 anterior jugular veins. And anterior jugular veins may be more than 2 or even single in number. That is called the median cervical vein, and should be preserving the anterior jugular vein to avoid the postoperative flap edema. Vessels of the intermediate compartment, that is the common carotid, internal carotid, external carotid arteries, and branches of the thyrocervical trunk. Here are the pictures. External carotid is important carotid artery. It originates from the carotid triangle at the level of upper border of the thyroid cartilage. Initially, it found in anterior and medial to the internal carotid artery, and it takes a gentle spiral course then and goes to the anterior and then lateral position related to the internal carotid. These are, it lies lateral to the styloid process and the connecting muscles. 12 nerve passes lateral hypoglossal nerve, that is, and glossopharyngeal nerve passes medial to external carotid arteries. These are the branches of the external carotid arteries, of which the superior thyroid artery is important for us. This is the it is the first branch of the external carotid arteries, has a critical relationship with the superior laryngeal nerve, lingual artery, facial artery, branches of the thyrocervical trunk, and also the inferior thyroid artery. It is the branch of thyrocervical trunk. It is important that in its course, before supplying the thyroid and the parathyroid gland in level 6, it has an intimate relationship with the recurrent laryngeal nerve. That is, the recurrent laryngeal nerve may pass the superficial to internal inferior thyroid artery, may pass deep to the internal artery, and may between the branches of the internal inferior thyroid artery. Internal carotid no branch, and internal jugular vein is important. This is the it is the continuation of the jugular valve, and in its level 2, it crossed on its lateral surface in descending order by the accessory nerve, spinal accessory nerve, occipital artery, digastric muscle. This is tributaries of internal jugular vein, and vessels of the deep compartment are vessels of vertebrovascular systems. Now the important nerves of the neck, this is the spinal accessory nerve, external branch of superior laryngeal nerve, recurrent nerve, hypoglossal, and so. I just touch the spinal accessory nerve, which is very important for us, head neck surgeon. Spinal accessory nerve descends from the jugular foramen near the medial wall of the internal jugular vein, medial wall, and deep and posterior to the plane of styloid process. The superior branch of it is important. The superior branch of occipital artery intimately related with the spinal accessory nerve. Okay. Then the identification. One of the important thing is that at this level, spinal accessory nerve associate with the anterior medial surface of sternocleidomastoid muscle in its upper third with anatomical variation. This is the anatomical variation, not penetrating, sometimes partially penetrating or completely penetrating. And the nerve enters the level 5 by crossing the posterior border of the sternocleidomastoid about 1 centimeter of Arp's point. Now the identification point of spinal accessory nerve during surgery. In 4 region we can identify at first entry point of sternocleidomastoid muscle along the anterior border of the sternocleidomastoid muscle, where the nerve is accompanied by the branch of occipital artery. Exit point about the 1 centimeter of Erb's point. The Erb's point in the point where the great auricular nerve emerges along the posterior border of sternocleidomastoid muscle. Also in the rope of the posterior triangle and in the lower neck, anterior edge of the trapezius, about the 2 to 5 centimeters superior to the clavicle. Here I have tips that careful elevation of the posterior skin flap is crucial to prevent the spinal accessory nerve, and at its entry point to sternocleidomastoid muscle, it is accompanied by the occipital artery, can cause the bleeding during the dissection at this level, and injudicious use of diathermy to stop bleeding may jeopardize the spinal accessory nerve. Then this is the external branch of superior laryngeal nerve. We have another session where Professor Ashikur Rahman Bhuya will discuss this nerve and relations. So that's all. Thank you everybody for patient hearing. Thank you. Thank you, sir.
Thank you, Professor Amjad, for your nice, concise and elaborate presentation. Now is the time for presenting the memento. May I now request Director NIENT, Professor Dr. Mohammad Zakaria Sarkar, to come on the dais and present the memento to the presenter and to the chairperson. First, I like to invite Professor Amjad Hussain to come on the dais and take his memento. Right. So now from the valuable comment from the chairpersons. First, I request on behalf of the chairpersons, I think Professor Khurshid Alam Majumdar sir will have a comment on this.
Anatomy, in fact, without the anatomy and the landmarks, the surgery of any region is very almost impossible, and Professor Amjad has nicely presented and described and the way how to approach the neck. The three layers of the skin, like Genji, Jama, tar upore coat, tinta layer, the superficial layer, investing layer, and the pretracheal and prevertebral layer, খুব সুন্দরভাবে আমরা ক্যারোটিড যেমন করে বলি সুন্দর করে একটা গোপাল ভাঁড় হঠাৎ করে পড়ে গেলেন, পড়ে যে আওয়াজ হওয়াতে বউ ওই দিক থেকে জিজ্ঞেস করলো যে এত আওয়াজ কিসের, বলে যে আমার পাঞ্জাবিটা পড়ছে, বলে পাঞ্জাবি পড়ছে তোমার এত আওয়াজ, বলে যে না ভিতরে আমি ছিলাম তো। কেমন আমরা যে ক্যারোটিড শীত বলি, ক্যারোটিড শীত মানে কিন্তু ভিতরে গুরুত্বপূর্ণ জিনিসগুলো আছে এভরিওয়্যার, বিকজ উই হ্যাভ টু অনার দি ক্যারোটিড শীত ইন দ্য লাইক দ্যাট, যে পাঞ্জাবির ভিতরে কিন্তু আমরা ছিলাম। হ্যাঁ, এনিওয়ে থ্যাংক ইউ ভেরি মাচ আমরা ফর দি প্রেজেন্টেশন এন্ড এভরিথিং।
Now some blessings and comments from Professor Dr. Nazmul Islam Munna.
আসসালামু আলাইকুম, শুভ সকাল। প্রফেসর আমজাদকে আমরা একটা বড় করে হাততালি দিতে পারতাম, এত সুন্দর করে সকালবেলা অ্যানাটমি বললেন, আমরা কৃপণের মতন হাত বন্ধ করে থাকলাম, দিনের শুরুটাই ভালো হলো না, একটা বড় হাততালি। প্রফেসর ডি রাজা চৌধুরী স্যার বলতেন, লিটল নলেজ অফ অ্যানাটমি, লিটল নলেজ অফ ফিজিওলজি অ্যান্ড প্যাথোলজি মেক্স এ সার্জন। ইএনটি সার্জনদের জন্য এটি অনেক বেশি প্রাসঙ্গিক, এবং প্রফেসর আমজাদ খুব রাইটলি সবচেয়ে কঠিন অ্যানাটমি জায়গাটা খুব সহজ করে বলেছেন। আমার মনে হয় দিনটা খুব ভালো যাবে। আর আয়োজকদের ধন্যবাদ জানাই। ন্যাশনাল ইনস্টিটিউট অফ ইএনটি আমাদের অ্যাপেক্স বডি, আমরা মনে করি সাউন্ড হিয়ারিং 2020 অ্যাচিভ করবার জন্য গুরুত্বপূর্ণ কাজটি তাদেরই করতে হবে, কিন্তু তার পাশাপাশি বাকি যে জায়গাগুলো আছে, সাব স্পেশালিটি যেগুলো আছে, তাদের প্রতিও সুবিচার করতে হবে, এবং সেই সুবিচারের অংশ হিসেবেই তারা হেডনেককে খুব প্রাসঙ্গিকভাবেই গুরুত্ব দিয়েছেন এবং সূচনা করেছেন। আয়োজকদের অভিনন্দন জানাই, শুভকামনা জানাই এবং আমাদের সকলের সম্মিলিত চেষ্টায় অটোলারিঙ্গোলজি অ্যান্ড হেডনেক সার্জারি বাংলাদেশে আরও বেশি জনপ্রিয় হোক। তরুণতর প্রজন্মরা নাক কান গলাকেই তাদের আগামী দিনের ভবিষ্যৎ হিসেবে বেছে নিক এবং সেই জায়গাটিতে আমরা সকলেই যার যার জায়গা থেকে আমরা যেন কন্ট্রিবিউট করতে পারি। সবাইকে অনেক ধন্যবাদ। আসসালামু আলাইকুম।
Now, Professor Nasim Yasmin. Our ENT is a barren subject. Ladies' participation is very few. So many ladies are coming. So Nasima Yasmin, Madam, is started ENT long ago. So let us have some comment from Professor Nasim Yasmin.
Assalamu alaikum. Thank you very much for giving me the opportunity to say something on this auspicious occasion. So I think I should appreciate that ENT has been tremendously progressing in our country nowadays. Especially, I think the credit goes to the seniors who have encouraged the juniors to participate in the subspecialties. So thank you very much to the seniors as well as the juniors and the organizers in National Institute of ENT. And once again, thanks a lot to Professor Amjad Hussain sir to give a very nice, give a various tips in the surgical anatomy of the neck. Thank you very much once again. Thank you.
Okay, now, ladies and gentlemen, put your hands together for our young surgeon, our rapporteur, Dr. Rafiul Rafi, and I request Professor Dr. Zakaria Sarkar to present a memento to rapporteur of this session, Dr. Rafiul Rafi. And then Professor Dr. Muhammad Zakaria Sarkar will present the memento to the chairpersons. Okay, thank you everybody. Now our next session. There is a lecture on head neck radiology by Dr. Muhammad Mahbubullah. Dr. Muhammad Mahbubullah is working as head neck radiologist in NIENT, and he will deliver his topic lecture on head neck radiology. May I now request Professor Dr. Muhammad Ashraful Islam and Professor Dr. Akhtaruzaman to come on the podium, to come on the dais and act as a chairperson of this session. Professor Dr. Muhammad Ashraful Islam and Professor Dr. Akhtaruzaman. And rapporteur of this session is Dr. Nazmul Islam. Dr. Nazmul, please come. Dr. Nazmul. Gazette involved. So Dr. Nazmul will be rapporteur on this session. So this is the session, lecture on head neck radiology, larynx, and allotted time is 15 minutes.
Sir, may I start the session? Thank you, sir. Good morning. Welcome to today's auspicious program in National Institute of ENT. And I am Dr. Muhammad Mahbubullah, working as Assistant Professor of Radiology Imaging Department of this institution, and I am going to start today's presentation with the permission of the chair, and my topic is head neck radiology, larynx. First, why imaging? Understanding the anatomic concept, review of laryngeal pathologies, diagnosis, staging of the disease, and management plan. And anatomy of the larynx. The larynx is a system of mucosal folds supported by cartilaginous framework. The upper edge of the epiglottis represents the most superior limit of the larynx. The epiglottis is the anterior boundary of the entrance into the larynx. Anteriorly to small sulci, the belliculi. Anatomy. How we divided the larynx in radiological division of the larynx. First, here the EROA. We first identified the hard palate, the posterior most part of the hard palate. We draw a horizontal line from the hard palate. Above the line, this is nasopharynx, and below the lines, it is oropharynx. And here, then we identify the hard palate. The posterior superior most part of the hard palate, we draw a horizontal line from the posterior superior most part of the hard palate. The upper portion is the oropharynx, and lower portion of the laryngopharynx and larynx. The three parallel structure, true buccal fold, false buccal fold, the ventricle, organize the larynx into three regions that are supraglottis, glottis, and subglottis. Here, a T1 MR image and a EROS 3D CT view. We see here is the ventricle, here is the laryngeal ventricle, the EROA. Above the ventricle is the supraglottis, and here is the true buccal fold. And above the ventricle, it is false buccal fold. It is true buccal fold. It is the glottis, and from true buccal fold up to the lower border of the cricoid. From true buccal fold below is subglottis, and here is the laryngeal ventricle. Above the false buccal fold, this is supraglottis, this is glottis, and below the area is subglottis. Same image, the supraglottis, glottis, and subglottis. Below the true buccal fold is subglottis. And same image, sagittal view. Here we identify the hyoid bone and draw a line perpendicular to the horizontal part of the hyoid bone, the supraglottis, and true buccal fold area is glottis, and below is subglottis. And now we go for axial images. And axial images, we first we draw a section at the level of the hyoid bone. Here you see the uppermost part of the larynx. It is epiglottis. The midline structure is median glossoepiglottic fold, and two EROA is air density areas are belliculi. And here is the it is T2 MRI. Same, the supraglottis area, the belliculi, epiglottis, and the EROA. And now we go at the level of middle part of the supraglottis. Here we see this is free portion of the epiglottis. There is the fixed portion of the epiglottis, and these are the paraglottic space. These are two piriform sinuses and posterior pharyngeal wall. And below, here also the ariepiglottic fold is started to appear. And below this level, at the lower part of the supraglottis, we see the ariepiglottic fold, the paraglottic spaces, and lower part of the piriform sinuses. And then at the level of glottis, how we identify glottic areas in CT scan. First, we see this is the circle area. This is the joint of cartilage. This is cricoid and arytenoid. Cricoarytenoid joint. Here is the cricoarytenoid joint. When cricoarytenoid joint appears in CT scan, it is the glottic area. And below the area, when there is a thyroid gland is appearing, and there is a semicircular or circular ring of the cartilaginous ring, this is subglottic area axially. And component of supraglottic component are epiglottis, ariepiglottic folds, and false buccal folds. Here is the graphical representation of the supraglottic area. We see the epiglottis, medium glossoepiglottic fold. These are the belliculi, and same in the CT scan. the epiglottis, median glossoepiglottic fold, pre-epiglottic space. This is the epiglottis. This is the midline structure, is median glossoepiglottic fold. This is epiglottis free margin, supraglottic. And below this level, we also see that here is the ariepiglottic fold started to appear, the pyriform sinuses and posterior pharyngeal wall, and these areas are pre-epiglottic space, and it is the fixed portion of the epiglottis at this level. And below this level, we see the ariepiglottic fold, the pyriform sinuses, posterior pharyngeal wall, and pre-epiglottic space. And most lowest part of the supraglottis, here is the ariepiglottic fold, pyriform sinus. And next, the glottic part will arrive. There is the glottic part of the true buccal fold, anterior commissure and posterior commissure. Graphic representation, so the cricoid cartilage, this is cricoid cartilage, this is arytenoid cartilage, this is cricoarytenoid joint, and this is the glottic, the buccalis and thyroarytenoid muscle. And in CT scan, we identify the cricoarytenoid joint, and the areas is glottic area. Subglottic includes undersurface of the true buccal cords to the lower border of the cricoid cartilage, and CT appearance, in axial CT appearance of the supraglottic, glottic and subglottic areas. Here supraglottic area airway, we see the ariepiglottic fold and pyriform sinuses. Behind there is no cartilaginous structure. When we go to glottic area, we do not see the pyriform sinuses or ariepiglottic fold, but we see the cricoid cartilage here and arytenoid cartilage here forming the cricoarytenoid joint, the glottic area. And below we see a circular ring, cartilaginous ring, and laterally we may found the thyroid lobe of hyperdense lobe of thyroid, then we can say that it is subglottic area. And in coronal graphic representation, the ventricle, above it is supraglottic area, the true buccal fold, it is glottic area, and below is subglottic area up to the lower border of the cricoid cartilage. And also same in the CT scan coronal, this is the laryngeal ventricle, this dilated part of the laryngeal ventricle, this is false buccal fold, this is supraglottic true buccal fold, this is glottic area, and below this up to the lower border of the cricoid cartilage is subglottic area. Now I am going to laryngeal carcinoma. First, glottic tumors. Carcinoma of the true cord is the most common form of the interlaryngeal growth. It presents early with hoarseness, is easily assessed by direct examination and has the best prognosis. However, involvement of the anterior commissure with spread of the other side worsens the prognosis. Here is a small lesion. Here is a small lesion. The cricoid cartilage, thyroid cartilage, the glottic area. Here is a small lesion in right true buccal fold, small elevation. Here is also, here is the small elevation, this is non-contrast and this is contrast scan, CT scan, and coronal scan shows here is the small lesion, the true glottic lesion, only involve the right buccal fold. And here is the upstage lesion of the glottic carcinoma. We see a lesion in the anterior commissure, the lesion irritating in the anterior part of the both part of the thyroid cartilage, and there is a large extension of the lesion in the preglottic area. Supraglottic tumors, these are best assessed endoscopically, but may be shown by their ragged appearance on the plain lateral radiograph. Growths arising in the bellicula or in the ventricle of the larynx may apparent on endoscopy or confirmed by biopsy. CT or MRI may be helpful by demonstrating invasion of the base of the tongue, obliteration of the ventricle, and erosion through the thyroid cartilage into the thyroid gland. Supraglottic cancers tend to spread directly into the upper deep cervical lymph nodes. Here the laryngeal ventricle, and here is the mass in supraglottic area. In CT scan, we see this is the laryngeal ventricle, this is true buccal fold, and lesion is above the true buccal fold, it is supraglottic tumor, but it extends upwards up to the epiglottis and bellicula. And also there is the small paralaryngeal extension. And, there is a tumor of upgrade stage of supraglottic tumor. We see both side of the right and left side of the supraglottic tumor. There is into the anterior part. The same here is the piriform fossa. This is the first upper limit, in upper part, and this is little bit lower part, the lesion. And in sagittal, we see a large lesion into the supraglottic area. We see in left side there is a large lesion into the supraglottic area. And lesion with supraglottic and glottic extension. Here we see a lesion in the supraglottic. Laryngeal ventricle is not identified, and the lesion extends up to the precoid cartilage, and this is supraglottic and glottic. Here we see the supraglottic area, and here is the glottic area, the glottic mass and the glottic mass. Also in sagittal, a large mass extended from the piriform sinus up to the true vocal fold. And disproportion tumor and lymph node, a small supraglottic mass in the thyroid level, hyoid cartilage level, hyoid bone level, and we see there is a large necrotic different sizes lymph nodes in both sides. Subglottic tumors, these are the least common type. The undersurface of the cord is the usual site of the origin and subsequent involvement of the vocal cord occurs. This region is difficult to assess endoscopically. MRI and CT may help by showing asymmetry. CT is to show invasion of the cartilaginous skeleton of the larynx by the tumor. And here you see a graphical subglottic tumor. This is the true glottic fold. Below is subglottic tumor up to the lower border of the cricoid cartilage, and we see in axial contrast CT scan a tumor in the subglottic area. There is a circumferential cartilaginous ring, so it is subglottic area, and also we find the thyroid lobe there, it is subglottic area. The lesion tends to invade the left lobe of the thyroid gland. Another subglottic mass, we see there is a circumferential tracheal ring, there is a mass in the right side of the tracheal wall. Also there is, the lesion involves the right lobe of the thyroid gland. There is some necrotic lymph nodes at level 4. Then staging of the tumor. T1 tumor limited to one subsite of supraglottis or glottis. T2 tumor invades mucosa of more than one adjacent subsite of supraglottis or glottis, or region outside the supraglottis, that is mucosa of base of the tongue, bellicula, medial of the piriform sinus. 3T tumor limited to larynx with vocal cord fixation or invades tissue beyond the larynx. There is a post-cricoid area, pre-epiglottic tissue, paraglottic space, or minor thyroid cartilage erosion. T4A tumor invades through the thyroid cartilage or invade tissue beyond the larynx. There is a trachea, deep intrinsic muscles of the tongue, step muscle, thyroid gland, and esophagus. And T4B tumor invades prevertebral space or encased carotid artery or invades mediastinal structure. Here is a T1 tumor, a small tumor. I saw it previously, a small lesion in the glottic area. It is a T1 tumor. Another tumor involves both sides of the supraglottic area. Okay, this is a T2 tumor. Here is a supraglottic glottic tumor, the supraglottic, the glottic involved, but we see there is a subtle erosion of the right lamina of the thyroid cartilage with mild paraglottic extension. This is a T3 tumor. We see patient has a tracheostomy, and there is huge air density area within the cervical tissue plane. The patient developed subcutaneous emphysema during tracheostomy. And we go for T4A tumor. There is a large tumor in supraglottic region, supraglottic glottic region. There is the gross erosion of the right thyroid cartilage and gross paralaryngeal extension. Here is the gross paralaryngeal extension and right thyroid cartilage is eroded. This is a T4A tumor. And this is also a T4A tumor. The supraglottic tumor that erodes the right thyroid cartilage, extension into the right paraglottic area. There is the multiple enlarged lymph nodes at level 3. Here is the enlarged lymph nodes, and there is the paraglottic extension of the tumor. And T4B tumor, when we see, so called it is T4B tumor, it is a, here is the tumor location in supraglottic area, in subglottic area, in subglottic area. There is the tracheal ring, and subglottic area, there is the extension of the prevertebral soft tissue, large soft tissue mass in prevertebral region. And here we see the lesion involves the thyroid, left lobe of the thyroid gland. It is T4B tumor. Then lymph nodes, N0 cervical lymph nodes not palpable, N1 palpable nodes unilateral not fixed, N2 palpable nodes bilateral, contralateral or midline nodes not fixed, N3 fixed cervical lymph nodes. And first we see a tumor, a supraglottic glottic tumor. There are the lymph nodes, unilateral lymph nodes, that is N1. That is also a N1 lymph node, supraglottic glottic lesion. There is lymph nodes in left side. There is the left sided cervical lymph nodes. This is also N1. Here is the cervical lymph nodes in left level 2 and 3. It is supraglottic N1 lymph node. And when we see supraglottic glottic mass with bilateral necrotic cervical lymph nodes, here the lymph nodes, large lymph nodes, here the lymph nodes, and also here the lymph nodes. This is a N2 disease. And here we see, I saw the lesion previously, there is a necrotic lymph node, a small lesion in the hyoid level, and there is a large necrotic lymph nodes appears invades the sternocleidomastoid muscles, also the internal jugular vein. This is N3. And this is end of my presentation. Thank you for patient hearing.
Thank you, Mahbub, for your nice and elaborate presentation. May I now request Professor Dr. Muhammad Ashraful Islam, sir, to have his expression and feelings regarding on this presentation and as a whole with the arrangement of the conference.
Thank you very much for the organizers. It is endless to say, it is very excellent organization and also the arrangements. Thanks to the organizers again, and also for inviting me in the auspicious gathering. I am lucky enough that I am the chairperson in this radiology, because I have a radiology book, Imaging in Otolaryngology, Head and Neck Surgery. I think many of you have seen this book, and this book is available in this library. I presented the book in this library as well. There is a first lecture was on the anatomy. So anatomy is your language. On this language, that is the radiology. This radiology is an articulation. This is the articulation and the anatomy. And there is a big thing in the radiology. Just I will highlight one or two things. Any radiologic things. One is the conventional X-ray, CT scan, MRI. The CT scan and MRI, the CT scan on the three sides. One is the coronal plane, one axial plane, and sagittal plane. What we look for? This coronal plane gives the only lines. The axial plane gives the dots. And sagittal plane, this is the combination of the dots and lines. So আমি একটু জুনিয়রদেরকে আমি খুব রিকোয়েস্ট করব যে প্রথম একটা নরমাল রেডিওলজি সিটি স্ক্যানটা দেখেন, তারপরে নরমাল, বিকজ ইট ইজ রেডিওলজি আমরা কখন করি, বিকজ ইট ইজ দ্য abnormal things, diseased one, and you go through the normal one and then compare the diseased one. So where is the defect of the anatomy? Then you can learn the radiology. What we are practicing, only we see the reports, but not the film. So do exercise on the films, and then you go for the operation. Then you just correlate what you have seen in the anatomy, what you have seen the normal, abnormal, and the practical. So the presentation was excellent, excellent presentation, and we have learned, I have learned many things out of this presentation. Thank you very much, Dr. Mamun, for allowing me to join here. Thank you very much.
So now chairperson's comment from Professor Dr. Muhammad Akhtaruzzaman. Please, very precise and concise form. We are already out of time.
আসসালামু আলাইকুম প্রথমেই আমি অর্গানাইজার যারা ফার্স্ট ন্যাশনাল ইএনটি মানে ওয়ার্কশপ করেছেন তাদেরকে আমি আমার অন্তঃস্থল থেকে আমি ধন্যবাদ জানাচ্ছি যে আমাকে এই ওয়ার্কশপে আমন্ত্রণ জানার জন্য। আমি একজন রিটায়ার্ড পারসন, আমি যশোর মেডিকেল কলেজ থেকে আমি প্রফেসর এবং প্রিন্সিপাল হিসেবে রিটায়ার করেছি। আমাকে আমন্ত্রণ জানিয়ে আমি প্রথমে ধন্যবাদ জানাচ্ছি। আর ইমেজিংয়ের কথা কি বলবো, আমরা যখন পাস করেছি, আমি 98-এ এফসিপিএস পাস করেছি, আমরা শুধুমাত্র প্লেন এক্সরে টমোগ্রাফির নাম শুনেছি কিন্তু আমরা দেখি নাই। বাট নাও ইট হ্যাজ কাম দ্য কম্পিউটারাইজ টমোগ্রাফি অ্যাজ ওয়েল অ্যাজ ম্যাগনেটিক রেজোনেন্স ইমেজিং। আমি শুধু এটুকু বলবো যে একজন হেড নেক সার্জন, ভালো হেড নেক সার্জন, যে কোনো, শুধু নট অনলি হেড নেক সার্জন, ইএনটি একজন সার্জন হতে গেলে ইমেজিং ছাড়া কোনো গতি নাই। কারণ আমরা ক্লিনিক্যালি, আমরা যখন করেছি স্টেজিং, আমরা ক্লিনিক্যালি জাস্ট দেখে আমরা ক্লিনিক্যালি করেছি, কিন্তু নাও ইট হ্যাজ কাম টু স্টেজিং, যেটা ইমেজিংয়ের উপরে স্টেজিং হচ্ছে এবং একজন সার্জন সে প্রথমেই বুঝে ফেলছে যে আমি কি করব, কতটুকু আমাকে করতে হবে, কি করতে হবে। তো থ্যাংক ইউ, আমি আবার ধন্যবাদ জানাচ্ছি আমাকে এখানে আমন্ত্রণ জানানোর জন্য। ধন্যবাদ। আসসালাম।
Thank you very much. Now is the time to present the memento. I request Director NIENT Professor Dr. Muhammad Zakaria Sarkar to come on the stage and present the memento to the presenter, moderators, and the chairpersons. To the presenter, to the presenter first, Dr. Muhammad Mahbubullah. Then rapporteur of this session, Dr. Nazmul. না ওইটা না, ওইটা ওইখানে শোপিস হিসাবে আছে। Now to chairperson, Professor Dr. Muhammad Akhtaruzzaman. And then to Professor Dr. Muhammad Ashraful Islam. Our next session, thank you very much. Give a big hand to the presenter and to the chairpersons. Now it is time to go to the operation theatre. So we will start our operating session with the photo.
আলাগের ভাই অপারেশনের ভিডিও দেন।
So assalamu alaikum.
ভিডিও
ঠিক আছে। So respected teachers and dear colleagues, assalamu alaikum and welcome to all.
হানিফ একটু আমি একটু আজকে এই সেশনের চেয়ারপারসনদের একটু ইন্ট্রোডিউস করে দেই, তারপর আমি আই উইল হ্যান্ড ওভার দ্য মাইক টু ইউ।
আগে জিজ্ঞেস করে ক্যান ইউ হিয়ার মি?
So now the live surgery session, we will start with thyroidectomy session. So this session will be chaired by Professor Dr. Muhammad Belayat Hossain Siddiqui and Professor Dr. Khurshid Alam Majumdar. Professor Dr. Belayat Hossain Siddiqui and Professor Dr. Khurshid Alam Majumdar sir, please come on the stage to chair the session, to chair this live surgery session. And I request live surgery. And this session will be moderated by two Yusufs of ENT, Professor Dr. Muhammad Yusuf and Professor Yusuf Haidar. Two Yusufs of this of our society will moderate this session. May I request two Yusufs please come on the stage. And rapporteur of this session is Dr. Utpal Kumar Sarkar. Dr. Utpal Kumar Sarkar, please report this session. So now I hand over the mic to Professor Hanif, Dr. Muhammad Hanif. Hanif, can you hear me?
Yes, sir.
Okay. So you please continue.
Thank you, Mohammad Murshid sir. Now welcome to all from the OT, and now the session is for live surgery of microscopic assistant hemithyroidectomy, and which will be demonstrate our respected sir, Professor Ashikur Rahman sir. Now the case summary, which will be told by Dr. Ripon Kumar Sarkar.
Assalamu alaikum. Welcome to all of you in first ethnic surgery workshop at NIENT. Today is our first case on thyroid. It will be demonstrated our Honorable Professor Dr. Ashikur Rahman Bhuya sir. On anesthesia, Assistant Professor Dr. Afzalur Rahman sir. Here the first case, Mrs. Hasina Begum, 60 years, female housewife, hailing from Shodor, Borguna, with the complaint of swelling in front of the neck for last 3 years. On local examination, there is an oval shaped swelling in the right side of the neck, measuring about 4 by 3 centimeter in size, moves with deglutition, smooth surface, firm in consistency, well defined margin, and not fixed with underlying structure and overlying skin. No palpable cervical lymph node is found. Here the thyroid function, patient is euthyroid. Both vocal cord are normal on FOL. On ultrasonography, right lobe of the thyroid gland is mildly enlarged inside. Soft tissue nodes noted in the right lobe of the thyroid gland, measuring about 3.8 by 2.1 centimeter. No neck node is found. Left lobe is normal. On cytological report, reported nodular goiter. So our final diagnosis is solitary thyroid goiter involving right lobe of the thyroid with euthyroid state. I think and our treatment plan is hemithyroidectomy, right, microscope assisted. I think the surgery and the demonstration will all of you enjoyable. Thank you.
Hello. Hello. Hello audience.
স্যার শুনতে পাচ্ছি স্যার
Hello.
স্যার শুনতে পাচ্ছি বলেন স্যার
হ্যাঁ আমি Dr. Ashik from UT. Am I audible to you, sir? Hello.
হ্যাঁ হ্যাঁ শোনা যাচ্ছে
Okay, thank you. So with due respect to the chair and my teachers, Professor Balayat Hussain Siddiqui sir, Professor Khurshid Alam Muzumdar sir, and our all teachers who present here, and all the delegates from different parts of the country, I welcome you all in today's live session. So my case already Dr. Ripon told us that this is a case of nodular goiter. The size of the nodule is about 4 into 3 centimeter, which is mobile, and it is not fixed with the skin or underlying structures. And there is so our plan of treatment is hemithyroidectomy on the right side, and I use a microscope for identification of external branch and parathyroid and recurrent angina. So let's start. So for the start, I used to first tell you that the all time we use the local. Here this is the local. You see here.
Professor Ashik, about the
sir,
positioning of the patient.
Right, position. Regarding the position of the patient is supine in position, and neck is extended. We given sandbag under the shoulder, and the head is slightly extended. Neck is slightly extended, and head is rested on the on a ring, head ring. So, and head end is slightly elevated, 15-degree elevated.
Professor Ashik,
sir.
This is Professor Balayat Hussain Siddiqui.
Sir.
Okay. Thank you very much for giving a brief description of your patient.
Sir.
Very nice description, and I think it is very clear to everybody.
Sir.
Now, and we are actually waiting to enjoy your surgery, and
sir.
Thank you very much.
Sir.
Thank you for this initiative.
Sir, actually I am.
But one thing at the beginning I shall give reminder. One thing, there is nothing local. It is a local anesthetic agent. So this is an academic session. So
sir.
Please. Okay, thank you.
Local means local infiltration. Usually all the surgeons use the local infiltration.
Audience can ask any question from here. audience can ask any question.
Yes, sir. You are allowed to ask any question and feel free to ask me. I will try to answer. If I could not able to answer the question, there are many teachers in front of me, they will answer inshallah.
Just as the points of disinfection, exposure, position you have started with.
Sir.
Please.
Regarding this draping. Actually, sir, already the operative field is disinfected by using the initially the hex scrub, and then it is washed by the 10% povidone iodine. And after that, we just draping here. You see the draping. I think we just draping the chest. It is the chest wall, and this is the leg end, and this is the head end. And I just open the lower part of the mandible and the chin. But as it is a benign case, and I did not do any neck dissection, so I did not open the mustard tip. So in case of for the juniors, if we do the neck dissection or any type of R&D or MRND or select, that time we should open the both mastoid tip and ear lobule. But as it is only thyroid, hemithyroid, so the draping is the limited draping.
ড্র্যাপিং এ উপরের দিকটাতে
স্যার
চীনের এখানে দুই দিকের এটা মধ্যখানে আসলে এটা সিমেট্রিক্যাল দেখা যেত, একটা আরেকটাকে কভার করে
এটা ডিউ টু স্যার ক্যামেরা,
এটা না তুমি বুঝো নাই
স্যার
আমার কথাটা। এই যে দুটো শীট, এই শীটটা এবং ওই শীটটা ক্রস করবে কিন্তু চীনের মধ্যখানে, so that ওটা সিমেট্রিটা এটা সিমেট্রিটা যেন সবসময় মেইনটেইন হয়, ওরিয়েন্টেড থাকে সার্জন এবং সবকিছু। কাজে এগুলো খুব ছোট ছোট টিপস, বাট ভেরি ইউজফুল।
থ্যাংক ইউ
very useful things.
Thank you, sir. It helps us all the delegates. Okay. So now come to the incision. So for juniors, what is the incision point?
তুমি কি মাথার নিচে বিড়া দিছো হেড রিং?
হ্যাঁ জি স্যার, জি হেড রিং আছে।
হেড রিং, আচ্ছা হেড রিং দেয়া না দেয়ার মধ্যে কোনো ডিফারেন্স আছে কি মনে করো?
Actually sir, head ring sometimes if the head ring is too large, then the extension is compromised. So sometimes we did not use head ring.
আচ্ছা, বাট হেড রিং এর সুবিধাটা কি?
সুবিধা advantage is the head is fixed.
স্টেবিলাইজ করে,
right, the stabilization of the head.
কারণ ডিসেকশন করার সময় আমরা যখন নাড়বো তখন কিন্তু জিনিসগুলো স্টেবল না থাকলে অনেক সময় ওরিয়েন্টেশন প্রবলেম হয়। Go forward please.
Right. Okay. So now come to the incision. No, local. We did not use local. So now come to this incision.
Local infiltration করে ফেলছো?
No. আমি বলতে চাচ্ছিলাম যে স্যার I do not use to local. This is the local. We all used to local, but our practice is not use any local.
Okay.
And why I did not use local, I just tell after 5 minutes.
Okay.
So now the marking. Give me the marking. So this is the suprasternal notch, and this is the thyroid notch, and this is the midline, and this is the leg end, and this is the head end. So this is the orientation, and this is the anterior border of the left sternocleidomastoid muscle, and is the right sternocleidomastoid muscle. So our incision plan will be in between thyroid notch and suprasternal notch, or somebody uses 2 finger above the suprasternal notch in a normal skin crease, or if there is no skin crease, then we can use the
আমরা একটু পরপর অবস্ট্রাকশন ফিল করছি বিশানে।
স্যার
ক্যামেরাটা যেন একটু পায়ের দিকে নিয়ে গেলে মনে হয় ভালো হবে।
ঠিক করো,
ক্যামেরাটা একটু পায়ের দিকে নিলে ভালো হবে। হ্যাঁ Okay, now it's okay.
Right. So the incision, that transverse incision, that was given 2 centimeter above the sternal notch, parallel or in a normal skin crease. But in this patient there is no skin crease. I see there is no skin crease. So I gave an incision about 2 finger above the sternal notch. Can you see, sir?
হ্যাঁ ঠিক আছে, কিন্তু ক্যামেরা অবস্ট্রাকশনটা একটু পরপর আসতেছে। ক্যামেরাটা বুঝতে পারে না মনে, ক্যামেরার প্লেস
আমি এখানে দেখতে পাচ্ছি তো।
ক্যামেরাটা কি ফিক্স?
না 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 চেঞ্জ করতেছি, চেঞ্জ করো না
একটু সাইড থেকে দেখ তোমার ফাইন
Okay, thank you, sir. Sir, this is the incision mark. Okay, sir? Okay. For juniors, if we give the incision lower, if somebody gives the incision lower, what is the problem? If given the lower, there is a chance of more scar mark. So, and if you plan the incision line above, then it will be a problem to the exposure. So, incision line should be in the proper place. Now I start my incision. First, I give an incision on the skin and up to the dermis. Are you getting the picture, sir?
Yeah, fine.
Sir, if you did not get the picture, sir, tell me.
থাইরয়েড সোয়েলিংটা খুব বড় হলে
স্যার
ইনসিশনটা যদি এভাবে দেয়া হয় অনেক সময় দেখা যায় যে পরবর্তীতে ইনসিশনটা অনেক নিচে চলে গেছে
রাইট রাইট স্যার রাইট
ইন মাই এক্সপেরিয়েন্স আই হ্যাভ সিন যে নেকের মধ্যে একটা ইনসিশন দিলাম
স্যার স্যার
অনেক জায়গা রেখে পেশেন্ট যখন 3 মাস পরে আসলো ইনসিশনটা বুকের মধ্যে
ইনসিশন লুকস লাইক আ স্টার্নাম, it seems to be